Becky, would you like to take the floor?
Of course, thank you.
Okay.
Yes, thank you so much for having me. I'll say that whilst I can see the screen, because once I start sharing, I can't see the screen. So thank you very much for having me. I hope this is a really useful session for you all. So I will share that screen there. Okay, brilliant. Can you all see that?
I can see it.
Brilliant, great. Okay, yeah, so I can't see anybody now, so if there is anything, please do just shout out to me. So my name is Becky Ashworth, as I've been introduced. I'm going to talk today about remote care and modern nursing, so the potential for what we can do in the future. And I do have remote monitoring experience as well, so I'll bring that into my presentation. Okay, so and what I'll cover very briefly in this, I'll be talking for about 45 minutes-ish. So I'll do an introduction into my background. Importantly, I'll be doing that because digital careers in nursing are becoming more and more popular right now. And so I'll talk about my route and how I got into digital. I'll briefly mention the digital landscape of healthcare and how that's changing. I'll talk obviously about what remote patient monitoring is and how that looks for the patients, and also what it's like from a nursing point of view to do remote monitoring. And because I'm a clinical safety officer, I fly the flag for digital clinical safety at every opportunity I can. So I'll briefly touch on what digital clinical safety is. And then I'll also look at the future. So what it could look like, what remote monitoring could look like in the short, medium, and longer term. So my background, yeah, I bring this up because it's I actually did a podcast on this recently with Future Nurse, and I talked with CNIOs about their experience, and everyone's journey into digital has been different because it's not really an established career at the moment. It's something that people seem to have kind of fallen into. So when I first graduated, I graduated in Leeds, and they had a medical rotation program where you could pick up to 3 places within the medical field to rotate, and then you could pick your favourite one at the end. I just wanted to do 2. So I did infectious diseases, acute ward. Really, my goal there was I wanted to do 6, 7 months on an acute ward, and ward work wasn't for me long term, but I knew I needed it as a foundation, and I'm glad I did it. And then I moved into the emergency department. And this was really where I found like the fire in my belly for nursing. I really enjoyed working in ED. And there are 2 hospitals in Leeds. So there's the LGI, and that is the trauma centre. And then there's Jimmy's, which is the medical. Jimmy's is in a slightly more rundown area. And really, everybody wanted to go to LGI, myself included, but I got Jimmy's. And I'm actually really glad that I did, because the patients that came into that department, they came in with the more kind of weird and wonderful symptoms, or they'd come in with the medical presentations where you'd have their vital signs and you'd have to look at their vitals, you'd have to do a good assessment to see what are their symptoms and look at their red flag symptoms. So it's more like a puzzle to put together and then make your clinical decisions from that. So it really formed the basis of my assessment skills in ED, and I've taken them with me throughout my career. Um, I moved actually quite quickly into infection research. So I came to nursing later on in my 20s. I'd done a bachelor in psychology and then I did my master's. And I'd actually worked in the NHS before that as a band 3 in mental health. And so I'd done about 10 years of shift work. And if I'm really honest with you, I wanted to move into research because I wanted to experience 9 to 5 and get some sleep. Um, and I really, really, really enjoyed it. I'd enjoyed my dissertation with my bachelor and my master's, so I did have an interest in research. But what I particularly liked about the research work was we talk a lot about evidence-based practice. Moving into research, you get to see how that evidence is established and how it's made. And I think it was really useful to have that kind of knowledge in the background when you're thinking about your clinical decision making, especially when you move to more advanced assessment skills, which I'm not at, but I'd love to get to. But it does really help you think about what good evidence is to help you back up your decisions. Obviously, everything went to COVID when the pandemic happened. So I did COVID research, and then I did COVID-19 human challenge trials, which I didn't know what that was until I applied for it. But human challenge trials are where we give healthy volunteers, usually weakened versions of the virus. So there's some in malaria and flu. And then we do lots and lots of investigations on them to see how that virus manifests. So we were the world's first to do that. We did that in England, were the first place to do that. We did it in London, and so that was a really cool experience. And it was research that brought me into digital. So Dockler is a virtual ward provider. They're a company that provides remote monitoring services to predominantly NHS clients. When I joined, they were quite small. There was maybe 2 or 3 contracts, and I was employed as a research nurse to lead the proof of concept study. And they basically said to me, you'll do that for 6 months, then after that, we've no idea what you'll be doing. And 3 years later, when I left, they were the UK's largest provider of virtual services, and they also had a CQC registered clinical monitoring team. So my career essentially just went along the trajectory of that company. So I got loads of experience around remote monitoring, which is it was a really, really good experience. I really enjoyed working there. And then I decided to leave that job last year just to shake the career up a little bit. And I now do part-time as a clinical advisor with NHS 111. So patients will call the service. Sometimes the clinician needs to call the patient back. And that's me that gives them a call back. So it's not remote monitoring, but it is remote assessment. And I also do consultancy work in digital, which is why I'm here tonight. And a lot of that work is working with NHS organizations working on like a strategic level on their digital transformation journey, and I do that as part of a team in my consultancy work. And then a picture on the right there is me with Spot the Dog at a recent event with Future Nurse, and Spot the Dog doesn't provide any kind of healthcare, but there's some really cool tech there, which Spot the Dog was the call it. If you aren't aware of who it's or what it is, give it a Google because it's some really cool technology. Okay. So if you're not already aware, but the 10-year NHS plan came out a few years ago, and I would recommend reading it if you haven't. It is quite a long document though, so do separate some time for that. But the 3 key shifts from that strategy is moving hospital to community. So thinking about how can we care for patients more in the community, and either hospital avoidance, so try and prevent them from going into hospital in the first place, or providing enough support in the community, or providing support for early discharge. So if the patient's staying in for some monitoring, is there something that we can do to do that monitoring in the community so the patients can get home? Moving from analog to digital, that kind of speaks for itself. Even in the 21st century, there are still hospitals or healthcare organisations that are using paper to record patient documentation, and there is an increased clinical risk in that. So it's looking at trying to move everything into digital and becoming paperless. And then from treatment to prevention. So there's 2 ways of looking at that. The first is obviously trying to, if we think about the scale of patients, but they're healthy, they deteriorate, and then they can end up in secondary care, trying to get that intervention in right at the very beginning. So potentially could be avoiding diseases to even progress in the first place. So if we think type 2 diabetes, a good example of that is if we can identify people with risk factors, can we intervene early enough to stop them developing type 2 diabetes at all? And then obviously there's the other way of looking at that, of long-term conditions, trying to prevent exacerbations of long-term conditions. And that also fits into the hospital avoidance as well. So what is remote monitoring? I will differentiate between virtual wards and remote monitoring to begin with, because they are generally used interchangeably, but the NHS definition does define virtual wards slightly differently. So virtual wards are about providing hospital level care in the community. So that fits quite nicely under that early discharge from hospitals. If you've got patients that you think, actually, we could send you home if we put this particular service in place, then that becomes a virtual ward. Remote monitoring is a bit more umbrella in terms of remote monitoring can cover that acute care, like that would come under a virtual ward, right through to long-term health management. And I'll give a couple of examples of those as we go along. Virtual wards have actually been around for decades. They and sometimes get called telehealthcare. A good example of that is if in COVID, there were some services where patients would be given a SATS probe and sent home, and then a nurse would give them a phone call and say, let's do your SATS, what's it showing, how are you feeling? And they document it in real time. Tech enabled is using technology to facilitate that process. So if we look at some of the devices on the left there, I'll use Dockler as my example, but there are other companies available. But Doppler, we would give, if a patient was referred on to a monitoring service, we'd give them a kit box, and in that box would contain devices like the BP cuff, the SATs, the tympanic, etc., and a smartphone as well that was pre-configured so that the patient could take their readings using the devices. The readings from those devices would Bluetooth over to the smartphone, and then the patient would look at the smartphone and say, yeah, and submit, and then those readings would get sent off. There was usually a questionnaire involved as well, so it would be specific to whatever pathway they were on, if it was asthma, diabetes, pediatric, etc. They would answer some questions as well and then submit those. On the right-hand side, there's the Doppler dashboard. Specifically, that's their News 2 dashboard. And so when those patients sent those readings off, it would come up on a dashboard, and then you can configure the software so that it prioritizes the patients the way that you want it to. So you can do, this wouldn't apply to News 2, but if you had a dashboard that was just showing the readings, you could apply parameters to individual patients. So you could say, for Mr. Smith, I don't want his BP going over 140. If it does that, I want it to be a red alert. Or Mrs. Smith, I want to put an amber alert if her BP falls to 90. So you can, and then that software that will then prioritize those patients for you. So as a clinician, you can go on and know which order you need to see your patients in. There's also video consultation on that dashboard there as well, usually, and there's usually messaging features as well, so you can use text messages to speak to the patients. A few years ago, I think it was 2022, I could be wrong on that date, but a few years ago, there was a big push from the government for healthcare organisations to start to establish virtual wards in respiratory and frailty. So respiratory works really well, and you can imagine quite easily how you would want that to work. Oh, someone speaking there. So you can think respiratory, it would work really well. Frailty, it was a bit more difficult, but I can understand why they wanted to do that. Frailty takes up a lot of space. In hospital, it's harder to discharge those patients. So if we can keep them and support them in the community, then that's it. It's a really it's financial benefit, but it's also good for the patients as well. So if we look at that traditional versus tech, the tech is more about enabling that care. And I think also when it goes well, when everything goes as it's supposed to, it actually can make the process a lot really efficient as well for both the patients and the clinicians. So as a clinician, I think I've touched on a few of these things, but so what does a remote monitoring nurse actually do? So they're utilising technology to monitor patients in a different location. So when I was doing it, I was based in London at the time. I was looking after patients in Hertfordshire, Southampton, Bristol. I think there's a couple up north as well. But essentially, that's what you're doing. You're looking after a patient outside of the traditional settings, and it's not in person, face to face. Our clinical monitoring team and myself, we would work remotely. So you could work from home as a nurse, which I wouldn't believe that would have been possible a few years ago. But you can also, some of the services were part of a hub. So for example, it could be a community nurse that would have patients, they were still saying face to face, but then they'd also have some patients on the remote monitoring. And the nice thing about working in hubs is you've still got that access. I mean, you still do when you're working from home, but it's via technology. You have to video call someone or send them a message. Whereas when you're in a hub, it's easier to just nip over. And if you've got some OT concerns, you can go to the OT team. If you want to escalate a clinical concern, the GPs are there. There'll be some, senior nurses, etc. So it is nice to be in that hub environment and have your team around you. And I think I touched when I talked on the dashboard about how the clinicians do that, but you log onto your laptop. The Doppler dashboard specifically was a URL, so you could technically access that on your mobile phone from anywhere around the world to go on and review those readings. And you would go through each patient profile, assess their vitals, assess the questionnaires, think, is this okay? Do I need to speak to the patient? Do I need to organise face-to-face visits? Or are they stable? They're okay, and you can just acknowledge their readings and move on to the next one. And obviously, you'd always act within your competencies. So assess the health data, make sure that you're confident in knowing what you're reading and knowing that it's safe, and anything outside of that, then you obviously escalate to other clinicians. So I do remember when I went into this remote monitoring, I do remember, my background was acute and it was emergency and it was all very wild and wonderful and lots of chaotic things going on. And I do remember thinking that remote monitoring, I was like, might be a little bit boring. I was incredibly wrong. I was very, very wrong. Remote monitoring can be done for patients who are quite acutely unwell and are really on the cusp of avoiding going into hospital. And it can also be for patients who have long-term conditions and you're just supporting that self-management. So there's a real array of the kind of patients you can be looking out for and caring for. And yeah, it was definitely not boring in any way. The other thing that I also didn't think ahead was actually how nice it would be for patients to be able to recover at home. So just keeping patients out of hospital alone. If we think about hospital or healthcare acquired infections, they're avoiding acquiring those infections. And if you think about if you're unwell enough, I've actually never, thankfully, touch wood, required a hospital admission, but I've been unwell in my time, and I don't want to imagine being more unwell. Those patients are unwell enough that they're needing to go into hospital, and then they're being asked to share a room sometimes with 5 other adults that they don't know. And then on top of that, there's the risk that they acquire a hospital infection. And there are stats to say that these hospital healthcare acquired infections are present in 7.6% of patients. So they're already unwell enough to be in hospital, and then they get that on top. And so that alone is nice to keep patients out. If we think about frailty patients or older patients, the British Geriatric Society claims that 35% of patients over the age of 65 don't return to full functionality after a hospital admission. So keeping those patients out of hospital is good for their long-term mobility. They keep going with their activities of daily living. It's really beneficial to keep them at home. There's also increased privacy. So the hospital curtains aren't soundproof, but if the patient is at home, they can talk freely and they get a more private consultation with their clinician. And as I mentioned, they don't have to share a room with people that they don't know. And there's also, this isn't so much for the patients, but there's the financial benefits of keeping patients out of hospital. So just keeping a patient in a hospital bed is around £400 per day, and that's without diagnostics or treatment. So we can save some money, hopefully, if we can keep patients out of hospital safely. One of the really cool things I learned when I was doing my research days, I went to this lecture and it was a guy who was running a microbiome study, and he talked about how I can't go into it too much because I haven't got enough time, but he did some research on some army cadets and found that when two young army cadets were sharing a room, and found that when one of them took antibiotics, it impacted the other person's microbiome. So there's been so much research in the last few years into how the microbiome, we know that it affects our mental health, our immune system, and our general well-being. When we bring patients into hospital, they have to really, because of the lack of resources, we can't be too flexible on that routine. So they're eating hospital food, they're waking up when we need them to wake up. They might even be taking meds for long-term conditions. It might be that clinicians now have to do that. So they have to take medications at certain times that they're not used to. They don't have their home, their dogs, their pets around, their family around, their usual nutrition. And all these things will have an impact on their immune system. I call them, they're like soft benefits, but I don't think we can underestimate how important that is to make sure that someone's in their home environment, and that will help their immune system keep going whilst they're recovering. They will have more access to their support network, as I've mentioned. And there was a patient who was on an asthma monitoring service who, because of that remote monitoring service being available for asthma patients in her area, she was able to continue working. She didn't have to worry about childcare, and she was able to manage that exacerbation at home. And so there's real benefits to patients being able to stay at home. And the other thing that patients reported was that increased communication with clinicians. And I think that's where the tech comes into it, because if you think about emails are easily lost. If you think trying to call someone, you both need to be free at the same time. When you've got technology there, you can use that to just send a text message. You can use it to send a message with your questionnaire saying, everything's fine, but actually I've got this going on. Can you give me a phone call just to talk about some different symptoms? And so the patients reported feeling that they had actually better communication with their clinician. Risks, however, there will always be a higher risk in remote care, telecare, any kind of care where the patient is in the community and not in a hospital setting. With remote monitoring, there's the risk of them sending in inaccurate health data, and then a patient might see that the readings are all within the parameters, click to say yes, that's fine, but actually the patient didn't take their readings correctly. You still don't have that. There are video consultation available usually, so you can do a visual assessment, but you still can't see necessarily everything going on. There might be, there might be reasons why you can't see like the home environment or, certain things that you would usually pick on visual cues. And when I did my community rapid response shifts, I'd never seen those patients before. They were always new to me. So I did a complete head to toe, and I would usually finish by feeling their calves and say, to assess if they had a DVT risk. You can't do that remotely. You can ask the patient to do it and report back, but it's not as reliable. And if you think about feeling pulse, for example, is it regular, irregular? You can't do that remotely, really. There's always a risk with remote monitoring that you're going to miss those safeguarding issues. So if you never do manage to see the patient's background or the home, you're not going to be able to pick up on neglect. You'll only ever be speaking to them, so you might not necessarily see if there's any issues within the network that they've got immediately around them. And safety netting advice becomes really important with remote monitoring, and there's a lot of overlap with community nursing, I think, as well. You're not going to have them in a hospital. You could have someone walking past their bay that might pick up that something's wrong, but you don't have that when the patient's at home. So your safety netting advice have to be really, really crucial, and you have to trust, or at least trust your assessment that the patient will be able to act on that safety net advice. You have to make sure that they have the capacity and the understanding to do that. And so the risk will always be higher, but the key with remote monitoring or anything where the patient is at home is to be continuously assessing that risk versus benefit. Is the benefits of the patient being at home greater than the risk of them deteriorating or coming to harm? And if it's the other way around, then you need to consider escalation to different services or secondary care. So how would a day in the life look like for a remote monitoring nurse? And this is what the shifts look like at Dockler. So it's very similar to ward-based work. So you've got your 12-hour shift. In the morning, there'll be a morning huddle, and patient groups will be allocated to different clinicians. So usually on the dashboard, you can click through and say, I'll pick up Hertfordshire today, I'll pick up Bristol today. And you can click through, and then those set of patients are shown to you as the clinician. Patients will submit their readings throughout the day. High acuity, it's usually 4 times a day, but then there's also patients who are submitting for long-term conditions, and that can be over months. So depending on the pathway and the acuity, the nurse to patient ratio can range from 1 to 10 to 1 to 50 plus. There's still the MDT meeting. These patients still need the multidisciplinary input. And then in the afternoon, there's usually a safety huddle. There might be time for additional training. And particularly for these clinicians, they were quite heavily involved in testing for the features for the new dashboard. So new features that would come out with the technology that the company was developing, they would be involved in testing and providing input on what they needed from the software. And throughout that day, they'd be calling patients, assessing readings and escalating clinical concerns, and just managing the care for that patient like you would in any other setting. So the skills and competencies that I need for remote monitoring, I mean, there's the obvious one of there does need to be a good understanding of technology. And I think that's becoming common now for any nurse training, really. There's going to be electronic patient records in most places that we work, and there's tech that we use as everyday care. There does need to be an additional step up that I don't think too many, especially nurses coming up now, I don't think too many would struggle with, but that understanding the use of smartphones and how Bluetooth works and manipulating the settings. There's going to be times when you're going to have to talk patients through how to change things if things go a bit awry. So having that good understanding of technology is needed. I can't stress enough how having an understanding of having a good foundation of assessment skills is needed for remote monitoring. There needs to be an understanding of the condition that the patient is on that pathway for. So if it's respiratory, have an understanding of respiratory conditions and how they present, if it's diabetes, etc., pediatrics, etc. And being able to do a good, thorough, comprehensive assessment. So not just the example that I use for this is not just focusing on that one condition. So when it was the pandemic, I was looking after patients. It was during that time when a lot of young people got really unwell and they were, on ICU and working their way off, and they could be on oxygen for months, slowly weaning them off. And so this was the pathway that I was working on. It was on an oxygen wean pathway. And there was a patient who was usually very fit and well, young guy. And I did my assessment. Everything was stable. It was the same. He was plodding along okay. And I say this usually at the end of most of my assessments, like any other aches or pains, any other symptoms, anything at all, whether you think it's related or not. And he was like, no, everything's fine. I've just got an ache in my calf, but I used to do lots of cycling, so I think it's just like muscular. And of course, a pain in your calf, you're thinking DVT. And then he's also got shortness of breath anyway because of the COVID and the weaning off. So that patient did end up being escalated. He went to ED and ended up being treated for a PE. So just having a good overall understanding of what red flags are is really important for this job. I think most jobs we come across will say you need excellent communication skills, absolutely for this role too, but I do think it's a step up, because being able to get that comprehensive assessment, understand what a patient's individual situation is, you're relying on communication to be able to do that and draw that information out. And equally, you need to be able to relay safety netting information to the patient really well. These services are usually a good opportunity for health education. So often patients will leave the services having an understanding of their readings because they've been taking them and what they mean. So being able to support patients through that and explain their health, that health data, those readings in a way that they understand is really important. And remote monitoring is quite innovative. We try to, especially at Doppler, they were always looking at the latest technology that was out and the devices that are out. Can we use this and implement this? So I think being able to think quite innovatively and be able to change your practice whilst maintaining safety is also a really good quality and skill to have. So how do we make sure that when we introduce technology, we're not disconnecting from the patient and actually we're still making sure and actually using it to enhance how we provide care? So the phrase we'll hear quite a lot in anybody that works in digital is technology should enhance care, not replace it. So one of the things that I used to do a lot with patients is when they were onboarded onto the service, I would spend the first few days, I would call them at least once a day, even if their readings were okay, just for a few days to build that rapport, gain more understanding of their situation, and etc. And just give them reassurance that there is a nurse on the other end of when they submit their readings. And usually after the sort of third or fourth day, I would say to them, okay, so we've got into a bit of a rhythm now. How about the next time you submit your readings, if everything's okay, I'll just send a read receipt. So I can send off a notification that says, clinician has reviewed your readings and everything's okay, I don't need to call you. And so, and I think that's one of the things that helped that patients feel like they had increased communication, because there are little features like that just let them know someone else is there, even if they don't necessarily need to speak to them, just gives them that reassurance. And so that comes under the sort of using the technology to connect with the patients and just letting them know that there is, and even patients who are on longer term services, I'd still call them at least once a week, just so they knew that their readings weren't being sent off into the ether, and also to find out if, whilst everything's okay with that particular condition that they're being monitored for, but is there anything else going on that might be affecting their health in their personal life. As you would in person, just always tailor the communication. So make sure you have an understanding of how much understanding the patient has, and making sure that you tailor your communication accordingly. One of the risks with using more and more technology is that nurses become more and more reliant on that technology to give them the healthcare data. So in ED, for example, if I had a patient in front of me that was grey and clammy, but then all of their vital signs looked normal, I wouldn't believe the technology. I'd believe my eyes. And so it's always important to remember that technology doesn't replace our clinical assessment skills. It just facilitates it. We still need to do our own assessment and make sure that we're confident that that patient is okay and that everything matches up. I've mentioned already that we can use remote monitoring to support health education. So I think that's another way to make sure that the remote monitoring is human-centered and it's individualistic to that patient. So you can support them to manage their health and understand their health, especially when it's longer-term conditions. And the safety net advice is always making sure that that is tailored to their unique home environment. So if a patient has a spouse, or they've got some older children living with them, a friend, a neighbour, you can say to them, are you happy for me to discuss this safety net advice with your partner, just so I know that someone else is aware of what's going on with your care. And that those notifications would work both ways as well. So you could send a message to a patient and then there'd be a read receipt that would come up. So it also gives you reassurance that you know that that patient's safe at the end of your shift, for example. I have done some presentation like this similar in the past, and one of the nice things when we built that clinical monitoring team is that I could ask some of the other nurses what their experience had been with remote monitoring, and they reported some things there on the side. So they found it was easier to provide truly patient-centered and individualized care. They thought it was a good opportunity to hone the assessment skills. They found they had more time with patients, and I think that might be related to if we think in ED or on the ward, you're going to constantly have things pulling at you all the time. Whereas these clinicians were working from home, they clicked in a patient profile, and then for that time being, their focus was purely on that patient. And so it does make you feel like you have a bit more time to give that care. And it's really nice working with patients who are happy to be at home. It's really quite rewarding. Especially when you've been in more higher pressured situations where people feel like they're not getting the care they need. It's a really nice experience to be providing care, and the patients are happy on the other end of it. Yeah, happy to be home. Okay, so I will just briefly go through digital clinical safety because obviously I fly the flag as a CSO anyway. But I do think it will become more prevalent as time goes on and digital becomes more and more embedded in our services. So digital clinical safety is a national NHS standard for ensuring that any technology that's used to provide patient care is safe for patients and doesn't introduce any kind of new risk. There's two guidelines. So there's the DCB 0129 and the DCB 0160. And the 129 is for the manufacturers of technology. So in my scenario, I worked predominantly under the 129 because the company that I worked for, Doppler, excuse me, they built the technology. They had a tech team who were making the technology. And so we had a list of risk assessment activities and deliverables that we needed to do under the DCB 0129. The DCB 0160 is for healthcare organisations. So in that previous example there, Doppler would make the technology. They would then pass that over to the healthcare organisation. The healthcare organisation would implement that technology and to care for their patients. And so they fell under the 0160 because they used that technology. It matters because any digital tool that we introduce, so from EPRs, remote monitoring, e-prescribing is a really nice good example of that, can introduce new types of clinical risk. So what if that software is built incorrectly? There's an error in that software. If we think e-prescribing, there's a risk there that the wrong medication is prescribed for the patient. The patient takes that medication, that can then result in patient harm. So we need to make sure that there's activities in place that reduce the chance of things going wrong. Nurses are often the first to spot any kind of unsafe workflow. So we are the profession that spends the most time with the patients, and therefore we're the profession that actually spends the most time with this technology as well. So we're usually the ones to spot when things don't go don't go the way that they should go. And so our roles as nurses is when we do spot something that's gone wrong, we report those incidents and near misses, the same as we would with clinical ones, and we do that early, especially with technology, because if you spot it going wrong with one patient, technology is usually used to help us manage care for many, many patients at the same time. So we want to make sure it's only one patient and not that it keeps snowballing and it goes wrong with lots of and multiple other patients. There is some e-learning available, which is free to do. It's on e-learning for health. I think you need an NHS email to get in, but it is free. It's digital. It's essentials of digital clinical safety, and that really is becoming more and more clinicians are needing to do it. It's becoming expected now that more and more clinicians are aware of it. So if you're interested in digital, absolutely do that training. So looking ahead at the sort of short, medium and longer term. So the short term potential is we've now had that boost of government funding in those early years. And so we've got some monitoring of virtual ward pathways that are now established. So ideally, in the next 1 to 3 years, there are more pathways that are developed and virtual wards become more routine as part of care. And it's used more often to discharge patients out of hospital and used more often to make sure that patients don't go into hospital. This presentation alone is a sign that students are we're considering digital training for students, so before students even graduate, and nurses hopefully become more confident in using digital tools, dashboards and data interpretation. So there is a framework called What Good Looks Like framework, and it's a framework that states the ideal for what the conditions for what digital transformation should happen in. And there's a more bespoke one that's been established that's just for clinicians. And one of those domains that they talk about in that framework is nurses being involved in being more involved in decisions and data-driven decisions. So I think over the next few years, there will hopefully be a push to increase data analysis skills within the nursing profession. And hopefully, if there's more virtual wards and remote monitoring services available, then there'll be more hybrid roles available. So it could be that nurses are able to work from home more as well as face-to-face. And one of the things I really like about that is if we think about workforce retention, we lose a lot of nurses year on year because they just can't, for many reasons, but just aren't able to do the profession anymore. There were nurses in the doctor remote monitoring team who had said if that role hadn't become available, they were considering leaving the nursing profession. They weren't physically able to do that hands-on work anymore. So more and more working from home positions potentially could support that workforce retention. And there was a lecturer that I spoke to once from York University a few years ago, and she talked about, this was really blue sky thinking, but talked about the idea of when you think about nursing as a profession, we're not actually the most inclusive nursing profession, despite the fact that we care for people with a multitude of health issues. And so someone who isn't physically able to complete the nurse training probably isn't going to look at nursing as a profession. But could it be that in the future that digital nursing becomes its own separate profession and that actually we have a course specifically for people who just want to do remote care using technology, and that would open up the potential for many people to join the profession and make it much more inclusive. So I think that that could be a potential that would be quite exciting. I'd love it if I saw that in my career lifetime. In the medium term, so I did miss out. So one of the things, I'll just point out the bloods test there. So one of the things that holds back virtual wards and remote monitoring at the moment is that sometimes patients need to stay in hospital because they have to have certain regular blood tests done that aren't available in the community. So if we're looking at the next, medium term, 3 to 7 years, certain blood tests, there is technology becoming available where there's going to be more point of care tests available. So more types of blood tests are easier, are more accessible, can be done outside of the hospital setting, and you get the results quicker. So the more that technology is developed, the easier it will be to support more virtual ward pathways. So the medium-term potential, so where there's the data-driven decision-making there on that population health insight. So the more technology that we use, the more health data that we're gathering. And to have that body of data, it would be amazing to be able to use that data and gain insights from it that then feed back into the services that we provide on a specific level, but then also feed back into population health insights. And nurses, because we spend the most time with our patients, we are well placed to be able to look at that data and say, actually, yes, I think this could be a good initiative in this particular population. Let's start doing something to support them. I've working at 111, there was a webinar not long ago where they had piloted using AI to assist their triaging, and it's particular. This was specific on skin conditions. So the patients had the option when you call. There's a recorded message that goes on for a while, and they had an option if it was skin conditions to select an AI triage tool, and that triage tool took the patients through its own assessment. There was options to send images and pictures, which AI could then also analyze, which is amazing for skin conditions because AI will be able to see certain things in there that the naked eye can't see. And then it meant by the time that patient got to a clinician, the clinician already had this wealth of data to be able to make an assessment for that patient and make sure that they had a better referral on. Because I think it's something like, this isn't related to skin conditions, but I think it's something like 60% of ambulances that are sent. There was a wild statistic that I wish I could remember now. That a chunk of ambulances that are sent from NHS 111 are either stood down or the patient doesn't need to go into hospital. By the nature of NHS 111, there's going to be referrals that ended up being not needed, but you can't rule out certain things over the phone. So any kind of technology that you can implement into that process is going to help efficient use of resources. There will be a stronger focus, hopefully, on digital clinical safety if I've got anything to do with it. And also there'll be further development of devices. So at the bottom there is the VivaLink wearable ECG monitor. And that isn't something that's available now. It goes onto the chest of the patient and it can provide minute by minute continuous monitoring. So you would log onto the dashboard. There's usually like a 2-3 minute delay, maximum 5. But you can log on and say, 2 minutes ago, Mr. Smith's heart rate was 68, his temperature's 36.5, his rest rate 18, all within normal ranges. And that provides continuous monitoring. So if you think as those wearable devices are being developed, that's going to support more virtual wards in the NHS definition of hospital level care in the community. The better those devices are at providing that continuous monitoring, the safer and the more pathways we can have into virtual ward services to help get patients out of hospital. And then 7+ years. So not long ago, I went to the University of Nottingham and they showed us around the labs that they've got there, and they were developing some really cool stuff. And one of the things that's quite exciting for the future in remote monitoring is smart textiles. So the image there on the left is a T-shirt that's been developed by MediBioSense, and it's a T-shirt that can take an ECG at the same time. So again, we can think about that in terms of that continuous monitoring for virtual wards. Also, thinking about inclusivity and making sure that we're developing technology that means everybody can benefit from these devices and this tech that's available. So if we think about patients that might not be able to tolerate a 72-hour ECG monitor, pop a T-shirt on them. It could be someone that's got sensory issues or someone that's got psychiatric issues or cognitive issues. Being able to pop a T-shirt on, we can then get that health data from them that we wouldn't have been able to do before. The image at the bottom there is a microfluid tip. So I mentioned that bloods is one of the things that holds back some of the pathways. This is technology that's been developed where a small chip is able to diagnose certain conditions and identify different levels of different things within the blood just from a tiny amount of fluid. And so that would facilitate, you wouldn't need much blood. It might help patients do their own blood tests as well, because you could do it from finger prick. and it would mean that you could do point of care at home. So again, more services available in the community. Also included in the NHS 10-year plan was the use of genomics. So if we think about mixing genomics then with remote monitoring, it could be that we've identified a patient is at risk, they've got the genes that could predispose them to a certain disease or presentation. We could then put some kind of technology, remote monitoring in place right from the beginning, so then we can monitor that patient's progression and monitor their risk factors and identify if we need to step in really early. So there's exciting things of when you think about if you're mixing different bits together with the genomics there and the remote monitoring. And then this is probably one of the, I've thrown a lot of information at you there, and I think I've talked quite fast through it all, but probably one of the main things I want, especially new graduates and student nurses, to take away, and this is really what Future Nurse is all about as well, actually. You're entering nursing at a time when things are really changing and technology is really transforming how we provide care. Nurses are the profession that spend the most time with the patients. And so we are best placed to be advocates for the patients and to shape that technology so that it works for the patients and works for you as well. Our expertise, by just being nurses and doing the jobs that we do, we hold the insight that can transform that technology and make it really work for patients and clinicians. And I would encourage you to check out the Future Nurse website. Essentially, Future Nurse is an organisation that's working with health tech partners to increase nurse innovation opportunities, so that when nurses have an idea, we can support them through we can link up with health tech and provide support for them to realise their innovative ideas. So to summarise, we are in a time where there's a shift towards utilising digital. That's in the NHS 10-year plan, and there is and digital fits into those three key shifts there that were mentioned at the beginning. Technology should be used to enhance care and not to replace it. Remote patient monitoring uses technology to allow clinicians to provide care from a separate location and offers multiple benefits for patients and clinicians as well. There are specific skills that nurses need to have to be competent in remote monitoring. So that is the good assessment skills, be able to use technology, and really good communication skills. There's always going to be risks in caring for patients remotely. So on top of that, nurses need to be really good at risk assessment and making sure and assessing that risk versus benefit. The more digital there is, the more we need to be aware of digital clinical safety guidelines. They are a legal requirement by manufacturers and healthcare organisations, and clinicians have a responsibility, everybody, under those guidelines to escalate concerns to make sure that the tech is safe. And the future, I think, is quite exciting. I think there's potential to see some really cool stuff, hopefully, in my nursing career. Tech is continuously improving. So the landscape for remote monitoring, I think, is quite an exciting place to be. And thank you very much. Yeah, I'll leave it there. And please do, check out the Future Nurse website. We've also got a LinkedIn page as well. And you can join the community if you want to. It's for nurses at every stage of their career.
Lovely. Becky, thanks so much. That was really, really interesting. I enjoyed that. Thanks, Noel. You said Noel said thank you as well. Anybody got any questions at all for Becky? I just think that was fascinating. Goodness me, some of those things with T-shirts and ECG and, the best way that we can serve patients through using technology. Fantastic stuff. Really good. Does anybody have anything they'd like to say? Any comment at all for Becky? Come on, there's 12. Oh, yeah. So Agnes has said, thank you very much. Very interesting developments. Anything from the students at all? Or ex-students, I shouldn't say that. You're staff nurses now, I imagine.
Hello, hi.
Lovely. Who's that?
It's Edith.
Edith. Hello, Edith. How are you doing?
I'm okay. Are you?
I'm very well, thank you. Yeah. Have you got a question for Becky?
Yes, I have a question for this group of patients. How do you get the initial referral for them? Um, to get them in as part of your patients. So is it a follow-up or from inpatient? How can you explain that to me, please?
So
Yeah,
where
of
do your
course.
referrals come from? I think is what Edith is
Yeah.
Yeah.
asking.
So, really good question. And it can be very dependent on the locality and the different NHS locations and services have different ways of doing it. But really, it can work from lots of different places. So it could be GP referrals. They could decide the same way it would work to a rapid response service. It could be that they decide, oh, actually, I want to put some monitoring in place for this patient, just see what their exacerbation goes like. So there are remote monitoring services where GPs would monitor. There were some ambulance crews where they were given kits and they carried them around on the van, and then they would assess patients and they could decide actually this patient could be really good for remote monitoring. And then it would usually be like a hub that they could call, a community hub. They'd call there and say, I've got a patient, I want to put them on monitoring. And they'd leave the kit with them. And then it can happen from secondary care as well. So it could be there were sometimes patients who were in hospital and they decided we're okay to send you home, but we need to do some monitoring, send them home with the kit and get them onboarded onto the service. And sometimes it was the staff at the hospital that would monitor those patients. Sometimes that would be a referral to the community hub, and the community hub would monitor those patients. But the referrals can come from lots of different places, and it does depend. My experience is all Dockler, but there are other remote monitoring services out there.
Mhm.
But they had their own customer service team, so they would work with the NHS clinicians, and they would do the onboarding to make sure the tech was working. They'd call the patient, help them submit their readings, and then the clinicians would carry on doing the monitoring.
So lovely. Does that answer your question, Edith?
Yes, yes. Thank you so much.
No
Thank
problem.
you.
I have a question from Crystal. It's in the chat. Crystal has said, and I know we discussed this earlier, which I have explained to
Mm.
Crystal, would you need to have ward-based experience for this role?
Um, so I think good background for this role could be ward-based experience. ED is a really good experience for this role. We did have paramedics on there as well. I think the most important thing is that you're confident in your assessment skills. So, and that happens on the ward. You can have patients, obviously patients will deteriorate on the ward, and your role would be to spot that. So that's the kind of experience that's really important for remote monitoring, is that being able to continuously assess the patient condition and be able to spot when when the patient's deteriorating.
Lovely, thank you. That's great. Hopefully that answered your question there, Crystal. So it's about really being quite uh, a good assessor, because actually we know, don't we, from what Becky was saying, that actually that's one of the risks, isn't it? That we need
Mm.
to make sure that that we can do that job also face to face.
Yeah.
So we've got Nawal has said, are there any digital or informatic courses you recommend to support our CV? I
Yeah.
think you, yeah, I think
I
you've
saw that, and as soon as
yeah.
I saw that, my mind went blank. But there will be ones,
Ah,
and I can send an email that we can send
okay,
on. The definitely the e-learning on digital clinical safety. Anybody that works in informatics and digital will need that. So
yeah.
definitely get that one done. I think it also shows quite proactive for any kind of job applications as well. And there are also I think NHIR. I will confirm this, but there was a course recently that was wanting to support clinicians in practice with their data analysis skills as well. So there are courses out there to try and upskill existing nurses so that they've got the digital skills you need. I'll send an email to confirm some stuff afterwards.
That's lovely. Thanks, Becky. We have a question from Maya. Maya has said, can a mental health nurse work in this field?
Oh, I want mental health nurses to work in this field. One of the and yeah,
More.
more. I think one of the really hard things that's been with remote monitoring is going to events and then mental health nurses or people in the mental health background saying, where is the services for mental health? And really, and this is probably one of the key things for any kind of working in digital, the tech is only built on experience. There needs to, I did work in mental health before, but it was band 3, so I don't know the ins and outs of psychiatric care, but there needs to be someone in that field that identifies an area that says, oh, we could do remote monitoring for this. For example, I think there was something about giving depot injections, and then a clinician needs to monitor them for 4 hours afterwards. So then you lose a clinician for 4 hours. Is there an option there to put in some remote monitoring? So absolutely, mental health nurses can work in this field, and I would encourage you to do that because there's a real gap there. I think there's a lot more that could be done.
Lovely. Great. Okay. Lovely. Thanks ever so much. Okay, we're drawing towards, well, we've gone beyond 7 o'clock. Let me just see if there's a couple more questions to take. Just got a thank you from Maya. Thank you very much. And Crystal said, thanks for the clarification around the ward-based experience and being a good assessor. Okay, folks. So I think given the time, we should close it there. But I think that has been really insightful. I really enjoyed it. And Becky, I hope you'll come back again and speak to us because your experience is really a key part to sort of working into the future with nursing. Thanks ever so much. I'm really grateful. Just to say to everybody and just to